I'll get us started. Welcome everybody to our first breakfast with WACh in a long time. Stephanie, I don't know when our last one was, probably before COVID.
Yeah, like 2 years ago.
Years ago, yeah. So thanks everybody for being here. Breakfast with WACh is an opportunity for us to have speakers addressing topics in maternal, child, and adolescent health. And we're lucky today to have two guest speakers with us from the University of Virginia and Emory. We're going to talk about a topic near and dear to many of our hearts, enteric infections. So I'll just introduce our two speakers. So we're first going to hear from James Platts-Mills, who's an associate professor of medicine in the Division of Infectious Diseases and International Health at the University of Virginia. His research focuses on the application of molecular diagnostics to the epidemiology of enteric diseases in children in low and middle income countries. This work has helped define the etiology and burden of diarrheal diseases and the impact of early enteric infections on child growth and development. He serves as a diarrheal disease expert for the Global Burden of Disease Study, sits on a WHO working group of enteric disease burden estimation, and with colleagues at the CDC and WHO, co-funded the Global Pediatric Diarrhea Surveillance Network. We're also going to hear from Liz Rogawski McQuade, who's an assistant professor at Emory University, Department of Epidemiology. Her training is in infectious disease epidemiology, and her research interests are in pediatric enteric diseases in low resource settings. Specifically, she focuses on the complex interactions between early childhood diarrhea, enteric infections, environmental enteropathy, antibiotic use, and their effects on child health and development. She's also interested in better understanding the impact of vaccines and other interventions for enteric diseases, and applies novel causal inference-based methods to generate epidemiologic evidence that is relevant to public health intervention and policy. So without further ado, I will hand it over to James. For those of you who are joining remotely, Stephanie will be looking at the chat, so you can ask questions in the chat, and we'll try to get those out into the group. And then obviously for those of you here in person, just raise your hand like the good old days. All right, cool.
Yeah. Well, thanks. Good morning. Congratulations on finding the room. I hope you're enjoying your new building and being in it finally.
James, did I have you talk?
Yes, into the mic. Yes, okay, we'll do it. Yeah, I hope everyone joining online can hear okay if I do this. Well, it's really nice to be here. I actually did speak in a do breakfast with some of you probably in, I think, like 2018. So it's nice to be here again. You might wonder why you have two speakers and why James from UVA and Liz from Emory are talking together. That's because Liz recently left the University of Virginia, but it's not a divorce. It's more of like a separation, and we're committed to continue to co-parent various projects, might even continue to start new projects together, hopefully. And it's really appropriate that we're giving this talk together because I don't think there are any of these questions or analyses or topics that we don't talk about together. So I'm going to do the first half, Liz will do the second half. But there's been a really, really enjoyable cross-pollination of ideas across a lot of this work. When I spoke in 2018, I talked a lot about diarrheal etiology specifically, which is where we really started in molecular diagnostics. I would say most of what we're going to talk about today is extensions beyond that. So I'll try to tie some threads together. Very happy to be interrupted. I don't know if I will know if there are questions.
Yeah, we'll interrupt you.
Well, okay, good.
Right, so,
Okay.
Yeah.
All right. Yeah, we're gonna try to cover a lot of ground. I'm probably not going to give enough methods for any single topic that we're going to cover. You're certainly welcome to interrupt or we can provide more detail, but to cover a lot of ground, we're going to kind of breeze over some different things we've been thinking about and analyzing. It's all tied together by this, a relationship between enteric infections and enteric dysfunction and growth failure as a marker of chronic malnutrition and the long-term consequences of that. We'll talk a little bit about some interventions related to enteric infectious diseases. We'll talk about a little bit just purely on the diagnostic side. We'll talk about growth and cognitive outcomes. So try to cover as much ground as we can. All right, so topic number one, though I'm not going to talk about molecular diagnostics purely that much. There are a few updates, iterations on the diagnostics that we've been using, which is quantitative PCR for enteric pathogens, that I thought would be nice to share in this forum. So one is an update in Shigella Diagnostics, which is the ability to do PCR serotyping directly on stool samples. So one of the most consistent messages from our application of quantitative PCR to diarrhea etiology is that we really underappreciated the burden of shigellosis using culture. It would be very striking between studies and between sites how insensitive culture can be, and very, very hard to standardize culture in such a way that you close that gap or even know how much of that gap remains. Certainly an important thing to try to do. So because we detect so much more Shigella by PCR, it is very tempting to use PCR in studies, including in efficacy studies of candidate Shigella vaccines. But because those are at least the most advanced candidates are quadrivalent vaccines where you'd expect better homotypic protection than heterotypic protection against other Shigella strains, it's very helpful if you can identify Shigella down to the serotype or species. So this is work that's been led by Gia Liu, who really developed the TAC cards and has advanced a lot of the molecular diagnostics and enterics for our group. She adapted a series of assays that had been used on isolates. So there's some good existing data that you can look for O antigen synthesis and O antigen modification genes from isolates and predict the serotype you've done with traditional methods. So what this figure shows is basically if you draw a line to any of the flexneri serotypes that are around the outside, the line from that serotype through to the genes in the middle are the genes that you would expect to detect if that serotype is present. So if you're trying to detect Shigella flexneri 5A, you should have detection of GTRV and OAC from an isolate. When you move to a stool, you have to work a little harder to be sure that it's relevant. So if you have Shigella detected because epidemiology, the primary gene target for Shigella, has a cycle threshold of 20, and you have OAC with a cycle threshold of 21, but GTRV with a cycle threshold of 34, which is to say you detected very little of it, then something's going on there that doesn't really seem consistent with that serotype. So she used paired isolates from the GEM study with stool samples and basically derived a quantitative scheme for whether the presence of these genes was consistent with the presence of the serotype from the isolate. So the rule she incorporates is that the cycle thresholds of the serotyping target should be close to the epidemiology cycle threshold. And if you need more than one target, so with the example I gave, you need both GTRV and OAC, then they should be within a couple cycle thresholds of each other to suggest that they're coming from the same organism in the stool. And that works quite well. It's not perfectly sensitive, but the specificity is very high. And since you're gaining so much sensitivity over culture to begin with, you're really focused on making sure you're not misidentifying serotypes. And by the way, when she went and investigated any discrepancies that there were, she was fairly convinced that PCR was right and the traditional serotyping wasn't based on the amplicon sequencing, though it's of course hard to know. So a good advance for being able to use qPCR as a primary microbiologic endpoint for Shigella vaccine trials in particular. And these assays have been incorporated into cards of diarrheal disease etiology studies, so we'll get much more data on Shigella serotype distribution, which will also be very helpful. One other update in Shigella Diagnostics is this question of whether you can infer resistance if you have detection of Shigella directly from a stool sample with an isolate. So you kind of have to do two things. One, you have to make a inference from genotype to phenotype, but you also have to do it from the resistome. So what you're detecting in a stool is presence of an AMR gene that may or may not be from Shigella. So I'll give one example for azithromycin. So there are a few figures on here. So I'll actually start with the one on the top with the label B on it. Up here, but I think if I do this, then online won't be able to know. So the top two bar plots, what you can see is a study from DACA, where children were admitted to ICDDRB and had culture done for Shigella and were treated with azithromycin and then had a follow-up. But in this case, the question was, did pre-treatment with azithromycin before the stool sample was obtained or before hospitalization affect the ability to recover Shigella? And it clearly did. So that about 25% in blue on the right are isolates of Shigella from children who did not get azithromycin, and then from the subset of 112 children who had received azithromycin before the stool sample was obtained, Shigella was not isolated from any of them. So it's nice to have that, to know that that's one very particular reason why there's a gap in detection between Shigella culture and PCR. Now, that's agnostic to whether the Shigella was resistant to azithromycin or not. So presumably, if it were resistant, then it wouldn't matter. From the same study, Neng Folwat, who works in our group at UVA, looked at cycle thresholds of resistance genes, namely ERMB and MIF-A for azithromycin, that confer azithromycin resistance broadly across a number of organisms. And she noted that if the difference between the cycle threshold of the resistance gene and epidemiology is low or negative, then you could, then it was fairly, could be resistant, or it could be susceptible. But if the cycle threshold gap was high, which is to say epidemiology was detected at quantities in excess of the resistance gene, then you can infer susceptibility. So that's kind of the message that we have, is it's reasonably sensitive, but it's poorly specific for both of these genes. And then this table at the bottom is basically using the cutoff that she derived from this figure to say basically what are the test characteristics of detection of a gene with a cycle threshold within 3 of epidemiology, and whether you could infer whether the phenotype was resistant. So effectively, there's a subset where you can confidently say it's susceptible, and then the rest you really can't say. And I think that's probably the best you're going to be able to do. Okay, a couple topics on a couple things in Shigella Diagnostics. That was popcorn, just in case you were wondering. So another lesson from the application of molecular diagnostics and culture-independent diagnostics in general is that the traditionally used culture techniques for Campylobacter was really just detecting the tip of the iceberg. It's a long story. In the Malad birth cohort study, one of the first projects I was asked to work on when I started my fellowship at UVA was, we have a problem, we have an enzyme immunoassay, and almost every stool sample is positive for Campylobacter. And what are we going to do? We think Campylobacter might be an important organism for long-term growth outcomes for children in these settings, and we have a lemon of an assay. So the question was, is it detecting Campylobacter? Is it detecting E. coli? Is it just not working at all? What's going on? And what we showed fairly convincingly is that it was positive when there was Campylobacter in the stool. It just wasn't necessarily Campylobacter jejuni. And in fact, probably 2/3 of the time, it wasn't Campylobacter jejuni. So there's an enzyme immunoassay that we had that detected a really broad range of Campylobacter species. And we launched confidently into a project that we could just do amplicon sequencing of the 16S gene from stool samples from 3 of the mallard sites and determine what Campylobacter species were present. 16S isn't perfect for classification to the species level, but for most Campylobacter species, it's quite good. There's a good conserved primers for getting an amplicon. So we launched into it. We had children from 3 of the cohorts in Bangladesh and Peru and Tanzania, a lot of samples, and did a lot of sequencing, and we used the Midiana platform so that we could multiplex 96 samples in each run, and we got sequence after sequence after sequence, completely overpowered number of sequences of 16S gene from these 4,000 some samples. And then we applied basically a bioinformatic pipeline that did K-mer-based classification to the Campylobacter species level. And we had to curate the reference database quite a lot. So for example, there's a subset of Campylobacter coli where the 16S gene is completely conserved with Campylobacter jejuni. If you leave those both in your reference database, your K-mer algorithm will just say, oh, can't classify that, can't classify that, can't classify that. So you have to run it and then look at the results and then think about, kind of get a phylogeny of your reference database, see what the distance is between all the individual species, and then whittle it down until it gets you the precision that you want and you can classify as well as you can. So ultimately, it could classify about 60% of the reads to a Campylobacter species, and very little to non-Campylobacter species, and that's good because the primers were supposed to be Campylobacter specific, and indeed they were. So we basically did this and then described this distribution of Campylobacter species across these 3 sites, and it was quite consistent that there were really 5 Campylobacter species of significant prevalence, with some variation between sites. Those were Campylobacter concisius, which is an oropharyngeal Campylobacter, Campylobacter infans, which I'll say a little bit more about, Campylobacter jejuni, / coli, hard to differentiate, Campylobacter troglodytes, probably won't say more about that, but could at some other time, and Campylobacter obsolensis, which is, been described, and with it's probably the non-jejuni coli Campylobacter we see the most of in the US, is presumed to be from dogs. You can see there's some difference, like you didn't really see any of this troglodytes in Peru, but infans was quite common at all 3 sites, and in Tanzania, a lot of detection of Campylobacter infans, even from the youngest kids. One of the things that really motivated us to look at this is that when we'd done the long-term growth outcome modeling using these Campylobacter assays, with the enzyme immunoassay, there was a quite strong association. This was published in Clinical Infectious Diseases a few years back now. Carolina Moore from our group in Hyden led the analysis and the writing of that paper, and really showed across all these mallard sites that children who had more Campylobacter detected by enzyme immunoassay had lower growth. When we applied the TAC cards to the same sample and had an assay that was specific to jejuni coli, it wasn't as convincing, the association between Campylobacter and growth. So we're kind of wondering, is it these other species that are really driving that association? So now, looking just at the subset from these 3 sites, you can see, so we still see this association with the enzyme immunoassay at the top, with some variation between sites. We don't see much of an association between jejuni coli from the TAC card PCR and growth. If we define non-jejuni coli Campylobacter just broadly as detection by enzyme immunoassay and not detection by the jejuni coli PCR, we see an association. And then when you look at the species-specific associations, it really seems to be driven by Campylobacter infans. That's a longer story. What is going on with Campylobacter infans, and something we're planning additional work to try to understand better. Campylobacter infans was recently described by Christine Szymanski, who was doing sequencing of GEMS samples, and was finding a lot of a Campylobacter species that she couldn't classify using a different gene, using ATPA, and then ultimately did some, metagenomically assembled genomes from those samples just directly from stool, and was able to get pretty good contigs for a whole genome. And then there's a subsequent isolate that's kind of confirmed that genome. And yeah, so it's something, stay tuned, I would say. Okay. We've just dabbled into seroepidemiology. There are a few potential applications of it in enterics. Probably the place where it's been used the most in enteric infectious diseases now is in typhoid, where blood culture is not available in most cases. Blood culture is poorly sensitive. There's a good vaccine, but you're not sure where to use it. Maybe you can go and do cross-sectional serosurveys in countries that don't have blood cultures, and then basically say, okay, this is where this country falls on the low to high incidence spectrum for typhoid. And you could potentially do serial cross-sectional serosurveys after a vaccine introduction to measure impact. Jason Andrews at Stanford is probably the person who's doing the most in that area. We have been collaborating with Chris Haney at Johns Hopkins to apply a series of Luminex assays that his lab has developed for enteric pathogens. And we've just kind of gotten our first pilot data together from the Malid Tanzania cohort. So I'll show you what we have and then just mention how we hope to apply it. So this figure on the top is basically every child in that cohort had a blood sample at 7, 15, and 24 months. And then they had serial stool samples collected every month and whenever they had diarrhea. And we asked, when you look for IgG to IPA-B, which is the black line that's rising up on the top, after a Shigella infection identified by stool PCR testing, do you see a fold increase over the prior baseline? So if you're looking at 15 months, you compare to the 7-month sample, 24 months, you compare to the 50-month sample, and for 7 months, you compare to effectively what you think the baseline negative, community baseline negative would be. And you do, this is a log 10 scale, so this is about a like 7 or 8-fold rise at the peak here, which is as expected, about 1 month after the infection was identified by stool testing, and then it stays elevated for 3-4 months, and then maybe starts to drop a little bit, and that's really the time window we have to look at. These are all negative control IgG mean fluorescent values for other pathogens. Just a series of other pathogens on the panel, just to confirm that it's specific, that you're seeing the response to Shigella specifically. The same multiplex Luminex assay has a number of other targets. So this black line is IPA-B, but there's also IPA-C and IPA-D, and then there's the quadrivalent strains that are included in the Shigella vaccine candidates. And our hope is whether we can use this as a tool to provide some external validation of the relevance of all of these additional detections of Shigella by PCR that we're assigning to be the etiology of diarrhea in the absence of the culture, culture positive. And one way we might do that is just to compare children who have culture positive shigellosis or PCR identified and culture negative shigellosis with acute and convalescent samples. And the EFGH study that we're here this week working on with Patty and her group would provide a really, really nice place to do that. Another question is whether it can confirm the PCR serotyping that I mentioned previously. Yeah, I think there are a few potential applications specifically for Shigella that we look forward to getting into more. Popcorn. I'm going to talk just a bit about the Global Pediatric Diarrhea Surveillance Network. So interestingly, all of the global estimating groups, and there are really two, the Global Burden of Disease Study, which I think you've heard of, and MICI, which is a group led by Bob Black at Johns Hopkins, has worked kind of internally and externally with the WHO to do diarrheal disease burden and etiology specific diarrhea mortality estimates previously. Both of those estimating groups use the assumption that if you can describe the causes of diarrhea requiring hospitalization, that you can use that as a reasonable proxy for the causes of fatal diarrhea. It's very hard to study diarrheal deaths. The assumption is that most of the deaths are occurring in children who don't have access to care. So this is kind of the next best thing, unless you're doing a study like CHAMPS, which will of course be interesting to see if you can study children who are dying of diarrhea directly, but it's incredibly difficult to do. Despite that assumption, there is very little direct data on children who are hospitalized with diarrhea using what we would argue now as a consensus is the best diagnostic approach using quantitative PCR. There was an existing global rotavirus surveillance network, and we were given the opportunity to build upon that surveillance network, add our assays to the regional reference labs that were already being used for rotavirus enzyme immunoassays and typing. And we now have the first 2 years of data from that network. It's been presented in a few meetings and is under review. So I want to share just a little bit from that. So for 2017 and 2018, we have 33 surveillance sites from 28 countries, all low and middle income countries. Some in Central and South America. You can see like 11 in Sub-Saharan Africa, Central Europe, Central Asia, East Asia, South Asia, and Southeast Asia. This is a quite a big network with almost 30,000 children hospitalized enrolled with diarrhea over 2 years. You can see the age distribution and the geographic distribution. This is almost all acute diarrhea. Any child admitted with diarrhea, regardless of duration, presence of blood is included, which required a bit of a rejig from how the rotavirus surveillance network was set up. You see about a little more than 5% with bloody diarrhea, which I think is about what you would expect. About 2/3 had vomiting. Most got rehydration therapy. Mortality was very low in hospital, as you would hope. We tested using these TACMAN array cards about 20% of all of the enrolled cases, and then we reweighted it to make it seasonally and demographically representative. And yeah, continuing with not showing you a lot of methods and showing you some as much as possible. These are the geographic groupings that we used and the etiology of diarrhea. And I think clearly the thing that comes out very quickly is that this overall, all of these aggregations are weighted. You have to aggregate up from the individual countries. They're all weighted to the diarrhea hospitalization incidence in the underlying countries. So this overall is very skewed towards West Africa, which includes Nigeria, where there are a lot of diarrhea hospitalizations. Though it's certainly there are diarrhea hospitalizations everywhere, so it's not that skewed, but there's still a lot of rotavirus. You can see in Central America and South America, which within this network are certainly the region that has had rotavirus vaccine introduced for the longest time. You can see rotavirus really coming back into the fold, into the mix with Shigella and norovirus and adenovirus as the other most common etiologies of diarrhea requiring hospitalization. And you can see even just a difference in East and Southern Africa, where there were more countries that had introduced vaccine, where it's down to 20% versus more like 40% in West Africa, where 2 of the 4 countries had not introduced vaccine and a third had just introduced. And you can see kind of what you'd expect. Maybe these East Asia sites are all from China. It's mostly rotavirus and norovirus. They haven't introduced rotavirus vaccine. I think that's what the US would have looked like before rotavirus vaccine was introduced. So you get a pretty good distribution. One thing that's always very striking is the amount of adenovirus 4041 in India, where it's really poised to be the leading cause of diarrhea requiring hospitalization, especially in infants. There's a lot of early adenovirus diarrhea, much more so like rotavirus than other pathogens that can peak in the second year. We can stratify this by introduction of rotavirus vaccine. And I think really the quick story would be before the vaccine introduction, it's 40 to 50% is rotavirus, and after it's about 20, which is a big impact, but it still leaves rotavirus as a very important pathogen and really makes the case for continuing to optimize rotavirus vaccine introduction and coverage. Think about the timing of doses, the possibility of introducing a neonatal dose is on the table, potentially a dose later in life, next generation vaccines. So there's still a lot of work on rotavirus vaccine development and use. since we made the claim that we were directly studying the proxy that was most useful for looking at diarrhea mortality, we figured, well, okay, let's use these 33 sites and do our own extrapolation just based on these data alone to what we think the causes of diarrheal deaths are. And we are using, because these sites don't have existing demographic systems to give incidence estimates around them, we worked with IHME to get country level diarrheal death incidence data from 2017. And then we applied it to this etiology data and put those together. So their envelope of total diarrheal deaths of any cause for each of these years, this is annual deaths, was 580,000, a little bit higher than their envelope had been previously, but that's the current model number. And you can see, yeah, still maybe about 35% rotavirus, and then Shigella, adenovirus, norovirus, and sapovirus, interestingly, after that. And you can clearly see the African region contributing most of the mortality as expected. So a lot of still preventable rotavirus diarrhea for sure. Yes.
Which question are you doing? TAC? Is that how?
Yes.
Okay.
So very happy to skip over the methods of the study because the application of the TAC data is complicated. This study does not have controls. So first of all, we need to apply attribution models that we had developed elsewhere. The concept being that if you're detecting pathogens by PCR for diarrheal stools, you know very well that if you have a child from the same area who does not have diarrhea, that you will detect many of the same pathogens. So you can't just say because it's detected in diarrhea that it's the cause. You would also then be assigning multiple causes to almost every episode of diarrhea. So in studies, in GEMS and MAL-ID studies I mentioned previously, both of which had a lot of non-diarrheal stools collected, we developed models of the association between pathogen quantity and having diarrhea such that you could say, well, yeah, Shigella detection, if the cycle threshold is 24, we basically never see that in a child who doesn't have diarrhea. You can very strongly identify that as the cause of diarrhea when you do detect it in a diarrheal stool. So those attribution models were imported and applying to GPDS, and then the other trick we applied was to use the variance in pathogen density between the MAL-ID and GEM sites to apply as much as possible like for like to GPDS. So for example, Brazil is one of the MAL-ID sites. The pathogen density is much lower in diarrheal and non-diarrheal stools there, which is to say when you detect a pathogen in diarrhea, you have a better inference that it's the cause of diarrhea. So the estimates from Europe for GPDS are heavily weighted towards the Brazil site because it's the most representative. It's not perfect. It would be lovely to have controls from all these countries, but that's how we're doing it. Yeah. And we're getting to work some, both with Global Burden of Disease Study and MICI to try to figure out the best way to look at studies that didn't use PCR and incorporate them into estimates so that you have more geographically representative data, but try to use it as well as you can. This is a study that Patty and Liz and I have talked about recently, so I just wanted to mention it here. It was recently published. This was doing TAC testing to look at etiology of diarrhea in a phase 3 rotacil vaccine trial done in Niger. Niger is at the time, I think was third highest diarrhea mortality of any country when this study was done. And it's just the nature of the research that we do, that we tend to do it in countries that have better infrastructure and better resources, even when we're in sub-Saharan Africa. And often it's the urban population that's easier to study or where the university is. So it is very helpful to have data from this sort of setting in Niamey in Niger, where MSF epicenter works. What was very striking from this cohort of almost 4,000 children who were followed for 2 years and had 1,729 episodes of vesicari greater than or equal to 7 diarrhea, so moderate to severe dehydrating diarrhea, tested by TAC, is not only that Shigella was the leading cause of diarrhea, but there was a lot of Shigella, and there was a lot of Shigella quite early. You can see the incidence of Shigella in 6 to 11 months, really, mirroring rotavirus. And you think of Shigella as really continuing to go up in the second year of life, but here there was the incidence was twice as high in 6 to 11 months as it was in 12 to 17 months, which is different than what we've seen, I would say, in most settings. This is using a Vesicari score, so that's going to move you towards infants a little bit more than just looking at any diarrhea, but all the same, it was quite striking. And if you look at severe, defined as Vesicari greater than or equal to 11, you see full 60% of it by the end of the first year of life and 37% before 9 months of age, which is the current plan for a 2-dose Shigella vaccine would be something like 6 and 9 months. So kind of full protection expected a few weeks after 9 months. So this raises the question of whether that's early enough in these settings. And if it's really as early as is feasible based on the vaccine and just the logistics of introducing a vaccine, then it certainly makes a priority to understand the indirect protection against those youngest infants and see if that burden is being averted. More popcorn. Okay. Maybe one more for me. I think we're doing okay here. I'm going to keep going unless I'm interrupted. Many of you are probably familiar with the Mordor Study. This was a study done by an ophthalmologist, Tom Lightman at UCSF, or the Proctor Foundation at UCSF, I should say, who had been studying mass drug administration of azithromycin for trachoma control in sub-Saharan Africa. And he's very assiduous, very observant. And he had noticed that there was an all-cause mortality benefit in these cluster randomized NDA studies of trachoma in villages that were randomized to azithromycin. So he approached the Gates Foundation and subsequently did a 3-country cluster randomized trial that was published in the New England Journal a couple of years ago. This study has already led to a WHO suggestion, recommendation in the highest mortality settings to use azithromycin mass drug administration. This is despite the fact that the mechanism is really not known. So there are a lot of theories about why giving azithromycin every 6 months would reduce mortality, and it was seen most in infants. Includes clearly a reduction in infectious deaths. Azithromycin does have activity against malaria, so perhaps it's that. Maybe it's reducing pneumococcal carriage and subsequent invasive disease and pneumonia from pneumococcus. Maybe it's diarrhea. There's some verbal autopsy data that along with the reduction in pneumonia, that dysentery was reduced by 35% in Niger, and Malawi diarrhea was reduced by 30% in the setting of azithromycin MDA. So there's certainly a suggestion from that enteric pathogens may be partially responsible. And there's certainly biological plausibility that if it were an enteric pathogen, it would be Shigella. We know the burden is high. We know it's treated by azithromycin, and that azithromycin susceptibility for Shigella in Africa is very high. And it's a host-restricted pathogen, so it would make sense that if you were giving rounds of MDA that you could significantly interrupt carriage and transmission. We know Niger has a lot of Shigella in particular. So we were able to get rectal swabs from a subset of the villages that were included in Mordor and test them using TAC cards. And what we saw was about a 2/3 reduction in Shigella detection from children at 24 months. So these are villages that at baseline 6, 12, 18 months got 4 rounds of azithromycin MDA. And then 6 months later, rectal swabs had a 2/3 reduction in Shigella detection in children from azithromycin villages. Pretty striking. This is under review. So why not? Campylobacter should be susceptible to azithromycin. The theory would be it's not host restricted, so you can treat children, but you're not really interrupting the significant reservoir for that organism. Popcorn. All right. Happy to answer questions now or later. Otherwise, we will keep rolling.
Are there any questions from the chat? Maybe we could just take a couple specific to James. No question. James, in the azithromycin Mordor stuff, did you look at the resistance in the TAC cards? Wasn't that like from what you did in Bangladesh?
Yeah, we did that in Bangladesh. I don't think that the Enteric cards had any of those AMR genes on them. Those are samples that we still have and could go back and look at, but I would say by and large, in sub-Saharan Africa for azithromycin, I just don't think there would be much. If you look at fluoroquinolone resistance, clearly in some sites in Asia, it's almost uniformly resistant. Azithromycin, there's a fair amount of resistance, especially in Sonii. But in sub-Saharan Africa, at least, I think broadly, especially in settings where azithromycin is not being used, there probably wouldn't be very much that we could look. Yeah. Great.
Is it your estimates of diarrheal mortality by pathogen based on the GPDS data? I think I got the acronyms right.
Yeah.
That was just using admission as a kind of proxy measure of the different causes of diarrhea. You didn't use mortality data from the inpatient setting in that calculation.
Yeah, that's right. So Craig is asking, when we're estimating diarrheal death etiology in GPDS, did we just use the subset of children who died in GPDS, or are we just saying hospitalization is a good proxy? And the answer is yes, we're using hospitalization as a good proxy. I would argue that actually trying to infer a case fatality rate or look at the deaths would probably lead you astray. And as an example, if you look in GEMS at rotavirus diarrhea among all comers enrolled with moderate to severe diarrhea, it was strongly predictive that that child was in the subset of about 20% who were hospitalized. But among hospitalized children, rotavirus was protective as an etiology against mortality, because if you have rotavirus and you have access to care and you get rehydrated, you do fine. So the argument is, if you would need IV rehydration and you don't have access to care, then that's an issue, and probably hospitalization is the best proxy for needing IV rehydration. Yeah. And those estimating studies take very different approaches, but they both use that proxy. Mickey says we're only going to use those highest quality studies of hospitalized children. And IHME, as is generally their approach, is we're going to use all the data we can get our hands on, but then we're going to make various adjustments to try to get to what we think we would find in hospitalized children and what we think we'd find with the best diagnostics.
One question in the chat. Could you please clarify if these samples were analyzed on site or shipped for analysis in the lab in the US? If it is the latter, what prevents adoption of your assay in LRS?
Low resource settings.
Oh, low resource settings.
That's for as a
Yeah.
bioengineer, so she's saying it
Yes.
from a bioengineering perspective.
Okay, yes, thank you. No, thanks for that question. So almost all of the data that I've presented, samples were tested in labs either in country or regionally. Most of this is not testing we've done in the US. Now, that is not to say that this assay would be a good assay to use in a clinical setting. It's too expensive. It's really good if you're looking for a really broad range of pathogens, but it's $50, $60 a sample, and you need the right PCR equipment to run it. However, it has been very nice for doing these kind of multi-site collaborative studies, because it's a closed system, it's very easy to train on, and we really believe the results are going to be consistent across labs. Probably the most important factor is sample handling and storage and cold chain, as it is, I think, with PCR being done anywhere. Yeah. Okay, I'll hand it over to Liz.
Wonderful, thank you, James. So as you see, our theme is to have a little bit on a lot of different topics. So James touched on diagnostics and a lot of burden applications. I'll be focusing more on intervention, projects related to interventions. But briefly, we'll first talk about kind of longer term impact of enteric infections. So most of you are likely familiar with the MALI-D study. So this was a longitudinal birth cohort conducted in 8 sites. The main study was only for the first 2 years of life. And Dick Grant at UVA was very interested and really pushed for much longer term follow-up anywhere he could get it. So ultimately we were able to get school-aged outcomes, so between 6 and 9 years, depending on the site, at 3 sites in Brazil, Tanzania, and South Africa. So we've just started analyzing kind of what the impact is of early life enteric infections and conditions are on these longer term school-age outcomes. There's a lot of concern that some of the early developmental tests, like the Bailey's, which were conducted in the first years of life, and even the WIPSI, the Wechsler test that was done at 5 years, maybe are not as useful or predictive of kind of longer term cognitive outcomes that we're interested in. And of course, anthropometry was also measured monthly and was also measured at 5 and the 6 to 9 year time point. So we have both growth and cognitive outcomes at later time points in a subset of sites. So first, just to talk about the linear growth piece. So there's a huge interest in stunting at 2 years of age, or linear growth faltering at 2 years of age. So what happens after 2 years of age? So these are just some smooth histograms basically of the length for HD score, the height for HD score at the different time points in these 3 sites. So on the left is the distribution at 2 years. So there's a huge variability across the MALAD sites. The yellow color is Brazil, which was generally kind of the least low resource of all the MALAD sites. And you can see that their distribution is right around the null, so there really wasn't much stunting in Brazil. Comparatively, there was quite a lot of stunting in South Africa in blue and Tanzania in gray. On the right is the same distribution, but at 5 years of age, and you can see they've all shifted up a little bit. So this is, some would say, evidence of catch-up growth. There's some controversy about using z-scores versus absolute differences, but you kind of, for both, I guess all 3 sites, you see kind of a narrowing of the distribution, and for South Africa and Tanzania, there's some catch-up. It's quite interesting then now comparing 5 years on the left to the later time point. This is the 6 to 9 year time point on the right. You see that South Africa in blue has now completely eclipsed Brazil. So there's complete catch up in South Africa, whereas in Tanzania, they're still faltering, with a large proportion of children that are stunted, continuing at 6 to 9 years of age. So trying to understand why there's catch up in some sites and not others, understanding whether that's really catch up or, less bad faltering in some sites versus others is something that we're interested in exploring. But it is interesting to understand what the impact of growth beyond this kind of 2 years time point, which we've latched onto with perhaps not enough evidence to do that. So onto the factors that affect these older outcomes. So just starting with kind of your basic sociodemographics, there were 2 main cognitive tests that were done at 6 to 9 years. One is the Ravens, which is kind of a puzzle test based on analogy. So you're given a series of puzzles and you have to find the missing link. And then the second one was the Nepsi test, a small subset of the Nepsi, wherein children were timed and were asked to list all of the animals that they could list in 1 minute and list all of the foods that they could list in 1 minute. And then they did the same for words that start with S and words that start with F. So a very simple test that tests your kind of cognitive fluency. And perhaps not surprisingly, the things we think of as basic sociodemographics are associated with improvements in your cognitive scores, as well as your height at 6 to 9 years. So the WAMI is a socioeconomic status score that was developed in MALAD, and it kind of has the strongest associations with these outcomes, as well as maternal education, maternal height, your enrollment weight, which is a kind of a proxy for birth weight, as well as family income. So not a huge surprise here, but some indication that these assessments are kind of measuring something that makes sense. We would expect to see these associations. Exclusive breastfeeding really didn't have an effect at all, and there were no kind of systematic differences by sex, which was nice to see, except for on height. What Dr. Grant is most interested in are early life pathogens and inflammation, of course. So this is what he wanted us to look at specifically. So looking at pathogen burden in the first 2 years of life and how that associates with these longer term outcomes. We've done a lot of work looking at early life pathogens and 2 year outcomes, and a little bit on 5 year outcomes. So essentially seeing, do these associations persist? First, just looking at the association between anthropometry measures and cognitive outcomes. We generally use anthropometry as a proxy for cognition because it's easier to measure. So does this work? And you do see that they're correlated. It's not a super strong association, but 1 z-score difference in length at 2 years correlates with an additional animal that you could come up with in a minute, for example. And you actually see that the association is about the same or even slightly stronger with height at the concurrent time point, so height at 6 to 9 years. So we have some idea that this 2-year time point for length is the best or the most important. It seems that measuring height later is as equally good of a predictor. So that's definitely something we want to explore more is, what's the best proxy for cognitive outcomes? And I'll talk about that a little bit more in a minute. Do these associations between pathogens on growth persist to later time points? I would say, first of all, this is 3 sites, and so the estimates are fairly imprecise, but we see the similar patterns. So viruses really don't have an association with lower length for HZ scores or height for HZ scores at this point. We see a slightly stronger negative association for bacteria and protozoa. We've seen that previously. We also see a small negative association with MPO, which is a marker of intestinal inflammation. And that's consistent with the kind of height outcomes at 2 years as well. On terms of the cognitive outcomes, there's really not strong associations with early life pathogen exposures. Maybe a little bit more convincing is the small negative association with intestinal inflammation with MPO. So kind of the takeaway from this is that pathogens in general don't have striking associations with these later term cognitive outcomes. When we look at specific pathogens, maybe our favorite pathogen becomes a little more interesting. So first, looking at specific pathogens and height at this later time point, so at 6 to 9 years. The one that pops out here is Shigella. So this is comparing children with a high burden to a low burden of Shigella in the first years of life, in association with their later height. And that's quite a big association. So kids with a high burden of Shigella had 0.3 on average lower Z-score in height at 6 to 9 years of age. And in these sites, specifically in Tanzania and South Africa, it was a similar effect size on height at 2 years of age. And of all the associations between pathogens and growth, Shigella was the only one that had a persistent association at height at 5 years. So we're seeing kind of a unique association between Shigella and growth that persists from 2 to 5 to now 6 to 9 years of age, at least in these subsets of sites, which is pretty cool. And while not particularly large associations or statistically significant, if you like to focus on that, Shigella did have kind of the largest negative associations with the cognitive outcomes at 6 to 9 years of age as well. Crypto is maybe the other interesting one. Interestingly, crypto was not associated with growth early at 2 years of age, overall in MALI-D or at the sites included in this analysis. But maybe there's a hint of negative association here. Try not to overinterpret these results just because we're at 3 sites and the numbers were getting small in terms of who we could find at 6 to 9 years, but it is somewhat consistent. Yeah, Karen.
The early life pathogen exposure, what time point was that?
So that's summarized over birth to 2 years. So it's similar to what we've done previously, is kind of the percentage of stools, non-diarrheal stools that were positive in the first 2 years. Yeah.
Is that the same thing for the mean MPO you showed on the previous slide? Was that early life first 2 years?
Yeah, and this is really preliminary. I don't really like how I'm summarizing MPO. MPO is, these biomarkers are very age dependent, and I think just averaging them is not really the best way to do it. So, well, yeah, maybe normalizing for age in the least, but trying to get some measure of summarized inflammation. It's interesting, AGP is the marker for systemic inflammation, and you really see nothing there. So we certainly see that Shigella, for example, is strongly in a dose-dependent manner associated with MPO. But I think the general thought is that systemic inflammation would be more important. So this seems to not suggest that. Yeah, Judd.
If you were to sample a kid sequentially over a Shigella infection, every day or something, how much variability would you expect to see in the burden? And I'm just wondering if, any given child at any given sample, the burden that you're attributing to it, could be just a function of when you sampled the kid as opposed to their true sort of worst case burden in that event.
Yeah, definitely true. We were just saying that this morning, that over, taking without kind of an incident infection date associated with a new diarrhea episode, for example, if you're just detecting Shigella in a random subclinical infection, you don't know, when the infection started, and there could be, we probably should not overinterpret a single quantity measurement for a single infection. That being said, we do see these kind of nice dose-response relationships. Maybe MPO is the most convincing, that the more Shigella there, even if it's a non-diarrheal stool, the larger the association with, increased MPO. So I think I agree with you, and also we have some data to suggest that the kind of isolated quantity measurements are useful. We haven't done kind of serial, we've talked about that, what if we did a new study, how frequently would we want to do stool samples and kind of try to characterize that daily variability.
At least if you had a positive, like doing a repeat 48 hours later or something, and then creating a curve of what infection looks like so that you could then standardize some sort of unknown peak burden or something.
Yeah, so we've done that specifically using diarrhea episodes as kind of a good start date to identify when the start of the infection was, so kind of characterizing the dynamics of quantity following what we call an attributable diarrhea episode. And on average, I don't know, maybe 2 weeks, you see that stools remain positive after kind of an attributable diarrhea episode, and that varies quite a bit by pathogen. So shorter for rotavirus, for example, longer for Cryptosporidium. But usually you see if you had diarrhea 2 days later, you still have the pathogen detected. It's just harder with the subclinical infections because you don't have that kind of start date that's clear. Yeah.
These were all subclinical infections.
These are all subclinical infections. You can add in the diarrheal stools, it doesn't change anything. These are also really preliminary. So working a lot with Rebecca Scharf at UVA on these analyses. So we always are kind of saying, oh, these are small numbers and just a few sites, but I think there's really few data looking at these longer term cognitive outcomes. So it's quite interesting. So maybe we're seeing evidence of this kind of Shigella inflammation to growth and potentially cognition pathway. Although I wouldn't say that it's, obviously set in stone. Okay, next topic. So I'll talk a little bit about illicit. So this was not my study, but I have been lucky to be collaborating as a part of it. This was led by Mark DeBoer at UVA, and James was one of the main investigators. It was a randomized 2x2 factorial double-blind placebo-controlled trial in Hyden, Tanzania, which James has mentioned earlier. The two interventions were scheduled antibiotics or antimicrobials, so azithromycin and nitazoxanide. And then the other intervention was daily nicotinamide, which is part of the tryptophan metabolism pathway. So it's slightly over 1,000 children that were enrolled. And the bottom line was that neither intervention affected either growth, which was measured at 18 months, the primary outcome, or cognitive scores at 18 months, which were measured by the Malawi Developmental Assessment Tool. So the figure on the top here is the distribution of length for HD scores at 18 months, which didn't differ between intervention arms, and the same for the MDOT score, which is the cognitive score. So obviously disappointing results. There's a lot of future analyses planned and ongoing to try to understand some of the mechanisms. So we're doing tag testing and looking at inflammatory biomarkers, breast milk sampling, microbiota, metabolomics, breath testing for SIBO, lots of different things to try to understand kind of what are the main pathways to stunting in this area. And it's been a really nice opportunity to have a larger birth cohort in Tanzania. So the Malawi study only had about 200 children per site, which made kind of within site analyses really limited. And so with illicit, we have almost 1,200 children from a single site. So that has allowed a lot of kind of interesting analyses as if illicit were an observational cohort. So one of the first things that we looked at, this is being led by infectious disease fellow James is at UVA. We're just kind of the risk factors for growth and cognition. Illicit is, I don't know if unique, but is a nice study that has both growth and cognitive outcomes. And so we can kind of interrogate the differences in the drivers of those two outcomes. So this is just a forest plot associating some of the baseline characteristics in illicit with the cognitive outcomes on the left and length for G-score on the right. And you can see that many of the drivers are similar. So enrollment weight, proxy for birth weight, is associated with higher enrollment rate, better growth, and better cognition. It's maybe not so surprising. What really stood out to us was this association with your birth month. So children who were born in September, October, November, December had much lower, a hugely different cognitive score compared to those who were born in July, August. And this was really specific to the cognitive score. So this was striking seasonality that was not so clear for the length outcome, but we did see that for the cognitive outcome. Your birth month is random-ish. And so we'll talk a little bit about what we think of the mechanism is, but it's a nice kind of quasi-randomized exposure to try to interrogate what are these pathways in which your birth month could affect cognitive score, but it's a pathway that doesn't affect your linear growth. So it's kind of a nice setup here to try to understand where growth and cognition track and where they don't track and what the shared and non-shared mechanisms are.
Did enrollment happen over the course of 1 year or more than 1 year?
It was over 1 full year. Yeah, and we spent a lot of time trying to understand whether this was kind of a spurious association based on the study design, and it really persisted. So let me just go one more slide. So the story here is really that in Hyden there's one single annual harvest. So there's very strong seasonal malnutrition in Hyden. This is data from MALI-D showing the proportion of mothers who report any food insecurity over the year. So during the harvest, there's very low food insecurity, and then during the rainy season, December through February, there's quite a lot of food insecurity and seasonal malnutrition. So I'll continue to show some slides showing how the seasonality manifests. But Karen, did you have a question? Yeah. So this is kind of the interesting story. Specifically looking at growth, so this is showing kind of the trajectories of length, weight, and head circumference Z-scores by your birth month and 2-month intervals. And it's a lot of lines here, but the general point is that there actually wasn't very much variability in length, much more variability in head circumference over here, and the variability that we see tracks much more closely with the seasonality of the cognitive scores. Suggesting that head circumference may be a better proxy than length. We kind of think, again, length at 2 years is the thing we should be looking at. This would suggest that perhaps cognition or the head circumference is a better proxy. And then also the timing is interesting here. So at enrollment or at birth, there wasn't a huge difference, but by around 6 to 9 years of age, around the time of weaning, you see 0.5 Z-score difference, just based on what month you were born. So we're trying to kind of interrogate that more and understand what could be the mechanisms of this seasonal variation in head circumference and cognitive scores.
Can I just editorialize just
Yeah.
a bit? I think this is so fascinating, but like that the head circumferences in the September, October born children are actually the highest at birth. I mean, I guess I always, this is not, this is us moving from work that's focuses into enterics, just recognizing something in a cohort in a setting where we work. That's clearly a reality, but I think that 3rd trimester is like like a lot of cognitive growth, and you think, well, actually those children were in utero during the best, the 3rd trimester during the kind of most nutritionally replete period of the year for moms after the harvest. But then their head circumferences and their weights are the lowest at 6 to 9 months. So is it, that's when those children are now into that kind of February, March, hardest part of the year. So is it breast milk quality? Is it introduction of complementary foods that are inadequate? It feels like that's the moment where something is going wrong for that birth cohort.
What month did you start enrollment in?
We started in September.
Which was the worst?
Yes. So one of the first things we wondered is, oh geez, are we having just a secular trend in the cognitive scores? But I don't think the scores are really asked in a way such that could be the case. They're just objectively assessed, and the growth data really tracks with it. And it was probably one of the worst harvests the year before, and a particularly poor rain. So I do think that this, maybe even is an outlier for Hyden in terms of how different it is over this year.
We did, was it something about the field workers that changed during the assessment? I mean, we kind of tried to go as far into that hole as we could, and we're really convinced that this is something that's a real phenomenon. And so we've also looked at admissions in the Hyden Lutheran Hospital, which is the main hospital in the area, and it is kind of really dovetails with this story quite nicely. This is the number of admissions per malnutrition, for malnutrition over the last 10 years. And we just have the numbers now. Where James is leading the setup of an HGSS in this area, so we can get denominators to get incidence. But even with just broad numbers, you can see really strongly seasonal patterns in malnutrition admissions by year. And when you kind of collapse this over years, you see malnutrition admissions track beautifully or not beautifully with the seasonality of food insecurity. And based on our kind of back of the envelope world pop estimates for population, we maybe see an incidence of like 7 per 1,000 child years in the hunger season, and 2 per 1,000 child years in the harvest season. So quite a big difference over the course of the year. And we see the same seasonality in admissions for prematurity in the maternity ward. And we see the same seasonality in mortality rates for all admissions. So this is kind of the overall mortality rate in the pediatric ward. One, it's strikingly, tragically high, and varies from below 5% to almost 9% over the course of the year. Hugely seasonal. Diarrhea, in contrast, has the opposite seasonality. So this is the seasonality of diarrhea. Sorry, this should say on the y-axis admissions. So it's driven by rotavirus still, and you see rotavirus peaks in the kind of off hunger season. But when we look at diarrhea mortality rates, so even though diarrhea is more common in the kind of harvest season, the mortality tracks the malnutrition seasonality. So I was quick to suggest that this means that malnutrition is underlying the mortality, which I think is probably partially true. It could also be that non-rotavirus causes of diarrhea like Shigella, which has similar seasonality to malnutrition, is driving the mortality. But I think we found this really fascinating. As James mentioned, this isn't kind of our primary area of research, but just has really highlighted what I see as a preventable burden, right? So just you shouldn't be dying more just because you happen to be sick in a different month of the year. It seems like it's a kind of low-hanging fruit for intervention. And so we're looking forward to figuring, thinking about ways that we can intervene in this area and kind of use the seasonality as a quasi-randomized type variable to understand mechanisms and how to make improvements.
It may be that if you get diarrhea in the off season where the peak is, that you could be anyone, everyone's getting diarrhea. But if you get diarrhea in the season where the mortality is highest, those are the malnourished kids and the vulnerable kids who are just, or they're getting Shigella or whatever, but those are, the kids themselves are at higher risk.
Right. Yeah, that's a good point.
They're just under recognition of malnutrition. They're kind of labeled with diarrhea on admission, and they aren't reaching for malnutrition interventions.
And the healthy kids just aren't presenting.
Yeah.
I think that's all I'm going to say about that. Moving on to WACh interventions. So thinking more about interventions, I'm sure most of you are familiar with the recent-ish large water sanitation and hygiene trials. So SHINE was the trial in rural Zimbabwe. As you likely know, it was a factorial trial of water sanitation and hygiene interventions and a feeding intervention. And neither intervention or combined had an impact on either diarrhea or linear growth at 18 months. So these, this was several years ago now. One of the primary questions was why were there no results? And so working with Eric at UVA, we were able to answer a small piece of this puzzle. Stool samples were collected and tested by TAC for enteric pathogens at UVA, and I was part of that analysis. And essentially what you see in this table is a bunch of sort of close to zero numbers. So there's essentially no difference in enteric pathogen carriage between any of the intervention arms in SHINE. So this was nice because it showed for us, there's some concerns that the association between water sanitation and growth were spurious, essentially, in observational studies, and this intervention trial showed us that. But we showed, well, really this intervention study couldn't have a referendum on that question because it didn't even impact the pathway that it was hypothesized to affect. So essentially the WACh interventions were not effective in interrupting transmission in this setting. And so we really don't know whether they could have impacted growth. So that was a nice small piece of that puzzle. And we worked with Jess Grenby at Stanford for a similar analysis in WACh Benefits Bangladesh with a small twist. So in WACh Benefits Bangladesh, there was no impact on growth. These are the distributions of length between intervention arms, but there was a fairly clear reduction in diarrhea. And when we looked at pathogens by TAC, there was really no difference in the bacteria or protozoa, but you did see a reduction in the enteric viruses. Enteric viruses cause a lot of diarrhea, and so this was kind of nicely consistent that we saw that the WACh interventions reduced viruses, saw a reduction in diarrhea, but they had no impact on the bacterial pathogens, which we think are more responsible for growth decrements. So these kind of combination of results were actually quite consistent with our kind of overall work. I've done a little bit of methodological work around these results. So, I think many in the room were very involved and interested in these studies. And there was some, I don't know, maybe backlash about these null trial results. So as I mentioned, we have consistently seen these observational associations between WACh factors and linear growth, but then we did these trials and we saw no effect. And so there was a lot of concerns that these observational studies were confounded. My lovely confounding monster.
Confounding looks like.
So I looked at these results and said kind of, wait a minute, well, we can't just blindly compare results from observational studies to intervention studies. Kind of the measure of effect that we're estimating is different between the two studies. So I like to show that with this diagram. So in an observational study, we're estimating the average treatment effect, which essentially is comparing what would have happened if everybody had the exposure to what would happen if no one had the exposure. And that's very different than what we estimate in a trial, which is essentially what is occurring under the baseline exposure compared to what is occurring after intervention. So in the observational study, we have this very disparate comparison, kind of everyone gets the intervention versus no one. Whereas in a trial, specifically of something like a water and sanitation intervention where there's already baseline access, we're comparing to the control group, which may already have, for example, improved sanitation, to whatever we can achieve in the trial, which is probably not 100% coverage. So clearly these two effects are not going to be the same and we can't just blindly compare them. What we can do is actually estimate this trial effect in observational data. So that's what I did. First in the control groups from the 3 trials. So I compared this adjusted average treatment effect comparing kids with improved sanitation to kids without improved sanitation to what we would expect to be the intervention effect. So if we had done a trial in the control group, what we would expect to see. And you can see that the association is always smaller, not surprisingly, because we're making a less extreme comparison. This population intervention effect assumes we could get 100% coverage, so that's even unrealistic. But you do see that the effect is smaller, and not hugely smaller, but right around the kind of effect that the studies were powered to detect. So the studies were powered to detect estimates of 0.15 in WACh benefits and 0.2 in SHINE. And so these are smaller than the studies were powered to detect. And we could have kind of predicted that before doing the study based on the observational data. I then did something similar with kind of all the data we could get our hands on. So that was MALI-D data, GEMS data, SHINE, WACh benefits, and then DHS data from a bunch of countries, and estimated intervention effects and average treatment effects, compared them, and described them across settings. So I don't have to go time, but I won't get into that too much. But systematically, your intervention effect is smaller than your average treatment effect, and you can make kind of better predictions for what your interventions can do in different settings using those methods. In this plot, I compare, variations of the effect based on how much coverage you're able to achieve in a trial. 100% coverage is probably not achievable. What if you could improve coverage by 30%? So it's really flexible in that you can kind of simulate the impact of interventions at different levels, that are able to achieve different levels of coverage. And we were looking at so much data that we could do somewhat of a meta-analysis to estimate these effects depending on your kind of baseline level of sanitation coverage, your baseline average length for HD score, for example. And so we would predict larger impact of these interventions in areas where there's low coverage of sanitation interventions already. Maybe that's kind of obvious. We also would expect larger impact in areas where there's lower mean LAZ. So in populations where children are doing the worst, we would expect the biggest impact of these sorts of interventions. So this work was in some ways kind of to provide context to some of the null WACh trial results, and then also provide a methodological tool that could be done in other settings as well. We should be estimating these intervention effects when we can, rather than kind of blindly comparing observational and intervention study results. So that was the kind of background of this work. All right. You haven't fallen off your chairs yet, so we'll keep going. So another kind of end result of, or fallout of these WACh trials was, a lot of concern that our interventions for WACh aren't good enough. And one perspective that we at UVA would take is, do they need to be more pathogen specific? So this is a study that's being PI'd by James and also Mami Taniuchi at UVA. We're calling SCAT. It's a transmission study for Campylobacter and Shigella. We're focusing on Campylobacter largely because of the work that James showed previously about non-Jejuni coli species being important and potentially have unique transmission routes that we'd like to characterize. And then Shigella, which we love, we've shown that culture is very insensitive, and so want to know more about Shigella transmission. These two pathogens are really nice to have kind of juxtaposed because Campylobacter is generally thought to be environmental transmission. Shigella is generally thought to be person-to-person transmission. So we're kind of both trying to verify that and also challenge that and see, is, for example, Shigella more environmentally mediated in low resource settings. So that'll be something that we're very interested in. With this study, really, we're planning to start early next year. It really takes advantage of the huge expertise in molecular diagnostics at UVA. So we're doing quantitative PCR testing in almost all the sample types in the F diagram. It's a small cohort of 100 kids in each site. So this is going to be in Dhaka and Bangladesh and also in Haidam. So we're doing qPCR in a bunch of environmental samples. We're kind of understanding what PCR detection means in soil, for example, by doing viability PCR. So understanding, is the stuff that you detect in soil, for example, actually live pathogen, and then doing some sequencing to try to kind of confirm associations between detections in the environment and in humans and the children. And then all of this data will feed into mathematical transmission models that will be led at the University of Michigan with Joe Eisenberg. So just briefly, it won't go through the whole kind of study design, but the idea is that we'll enroll 100 children at each site kind of evenly throughout a year-long period, and then have very intensive sampling. So every month we'll do kind of a suite of environmental samples and stool samples, not just of children. So we're targeting children under the age of 1, but we're really enrolling the whole family to also get human-to-human household level transmission. So we'll be collecting stool samples from all the family members, doing kind of comprehensive environmental sampling every month, then having intensive diarrhea surveillance on top of that, so twice-weekly surveillance for diarrhea. When diarrhea occurs, doing another round of environmental sampling. So really trying to characterize kind of pathogen dynamics in the environment and in the families over the course of the year. We're also going to do a little bit of serology because we're dabbling into that and incorporating kind of structured observations to parameterize some of the kind of contacts between children and these contaminated environments. So I think we're really excited about this study. It brings together a lot of our interests. Stay tuned for how that
A little
goes.
bit on the environmental sampling, like where are you sampling and how much are you sampling? Yeah, how is that?
Yeah, so these are all things we're kind of in the process of protocolizing. I think our instinct is to get kind of consensus samples. So instead of just taking like a small soil sample in one place, trying to get kind of a representative sample of the soil environment.
You like target fecal fields or like household doorways, or it's just more?
Yeah. So we're going to focus on kind of the immediate living space. In DACA, that's really the only relevant thing. It's the urban area, and then in Hyden also kind of the most immediate living space, including around the doorway. I think we talked about asking where the child spends the most time or plays. One thing to make it a little bit kind of a constrained problem is we're really trying to focus on the kind of direct exposure to the child. And these are very young children, they're going to be between 0 and 2 years of age, so they're not hugely mobile. So kind of trying to sample directly around the child and get that kind of most immediate link will be the focus. Yeah.
How many households are you following?
Yeah, so it's 100 in each site. Okay, I think the last topic. Maybe. No, I think it is. Okay, so the last thing, we're still in interventions, a lot of focus on enteric vaccines. So we have a small grant from the Wellcome Trust to expand the value proposition for enteric vaccines by understanding kind of the burden of antibiotic use that could be prevented by enteric vaccines. So this is really a direct extension of the etiology work that we've done previously. But for example, this plot shows the attributable incidence of antibiotic use for each enteric pathogen. So overall for any antibiotics, Shigella is the leading cause of antibiotic use. Not surprisingly, Shigella is the leading cause of diarrhea, and it also causes dysentery, which gets treated almost all the time. And is the leading cause of every class of antibiotics except for penicillins. Rotavirus, not surprisingly, is the second leading cause. It causes a lot of diarrhea that gets treated erroneously. So even though rotavirus shouldn't be treated, it still is a major cause of antibiotic use. So overall, Shigella causes about 12% of antibiotic use for diarrhea, 20% of fluoroquinolone and macrolide use, which is much more than some other comparator pathogens. I didn't mention, but this is all in MALI-D, so this is an extension of the MALI-D study. And what's nice about MALI-D is that we don't just have antibiotics for diarrhea, but we have antibiotics for all indications. So we can calculate that Shigella is actually responsible for 3% of all antibiotics ever given to these kids. They get a lot of antibiotics for a lot of things, so maybe that seems modest, but when you look at specific classes of interest like fluoroquinolones and macrolides, it's a reasonable amount. So Shigella is responsible, for example, for 12% of fluoroquinolone uses in these kids. So the idea is that if you had a Shigella vaccine, you could prevent quite a sizable burden of antibiotic use in these kids. Of course, MALI-D was a community study, so we kind of have the full envelope of antibiotic exposures in these kids. And it turns out that it's not just that Shigella is the leading cause of diarrhea, so it's the leading cause of antibiotic use. Shigella and rotavirus are both disproportionately more likely to be associated with antibiotic treatment than other pathogens. So these are just associations of association between a specific etiology and antibiotic use. They're all null except for Shigella and rotavirus. So Shigella is 50% more likely to be treated with antibiotics compared to other etiologies, and rotavirus is about 20% more likely to be treated. Of course, in these settings, we don't have point of care diagnostics, so It's not that physicians are saying, oh, you have Shigella, let me treat you. There's something else going on here. So we did a little mediation analysis to show that much of this association is due to the increased severity of both Shigella and rotavirus and association of Shigella with dysentery. Not hugely surprising or groundbreaking, but I think just nice to show. Maybe I'll just briefly say that severity and dysentery can explain about half of the association between these pathogens and antibiotic use. The other extension to this, which I think is kind of maybe a bit more novel, is understanding bystander exposure to antibiotics. So certainly we know that carriage of enteric pathogens is hugely common in these settings. And so when a kid gets antibiotics, it doesn't just affect the pathogen causing the illness requiring treatment, but it also affects all of the pathogens carried subclinically. So we tried to quantify that in MALID as well. So essentially for every antibiotic course, we identified which pathogens were also affected by that course of antibiotics. And it happens, you know, it's extremely common. So enteroagglutinated aggregated E. coli, for example, is detected in like half of the stool samples. So almost every time you get antibiotics, you're exposing that pathogen to antibiotics as well. So over here to any antibiotic, this bar is saying essentially, yeah, it gets exposed to antibiotics, you know, 2 or 3 times a year in these kids. And these bars are broken down, basically breaking up exposure for each pathogen for when that pathogen was a subclinical infection, so it wasn't the cause of treatment, to when it was the cause of treatment. And you can see like the vast majority of treatments were when these pathogens are subclinical. So they're being treated, but they're not trying to be treated. It's a bystander exposure. The one exception to that is Shigella. So for example, for fluoroquinolone use, you know, more than half the exposures to fluoroquinolones for Shigella are actually because of Shigella diarrhea. But that's really an outlier. You know, the vast majority of antibiotic exposures are when these pathogens are just bystanders. And then to this goal of expanding the vaccine value proposition, we can attribute that bystander exposure to specific pathogens. And as we know, Shigella causes a lot of antibiotic use. So Shigella causes a sizable portion of that bystander exposure. So it causes, you know, 30 exposures per 100 child years, or 4% or so of all the overall pathogen exposures to antibiotics. So this is trying to kind of build the evidence base for kind of what are the ancillary benefits of potential vaccines like Shigella vaccines. Okay, very last piece, I promise. There's also a lot of interest in expanding the vaccine value proposition for understanding the effects of vaccines on growth. So we've kind of shown these observational associations between pathogens and growth. If we had a vaccine, wouldn't we be able to improve growth? So I did this kind of small analysis as part of the primary analysis of pathogens and growth in MALID, which most of you probably missed, but it was my favorite part of the analysis. It applies these intervention effect ideas. So what I did was, in the observational MALID cohort, essentially simulated the impact of a perfect vaccine on growth. And I focused on a perfect vaccine against the 4 pathogens that are most strongly associated with growth. So that's Shigella, Giardia, Giardia, and Campylobacter. And estimated that if we had a vaccine that essentially could prevent exposure to those pathogens, all exposures, including subclinical exposures, that we would improve LAZ from the current average by about 0.24 z-scores, which is not huge, but it's comparable to what we can achieve with nutritional interventions. It is also assuming we have a perfect vaccine that is not only, you know, prevents these 4 pathogens, but it prevents, you know, sterilizing immunity, it prevents subclinical infections. So this is not realistic, but it's more realistic than just looking at the observational associations. And this was so depressing that it didn't really get published yet, but if we just look at a perfect vaccine against Shigella, you just see very little overall improvement, expected improvement in LAZ. So if we could prevent all Shigella exposures in MALID, we would expect, you know, a 0.03 improvement in average length in the cohorts. And this is how interventions work, right? Shigella is the most strongly associated with poor growth, but it's not the most common pathogen. So if you do a vaccine, some kids never would have gotten Shigella anyway. So you're not going to affect those children. You can only prevent Shigella in the subset who would have gotten it. And it just turns out that the kind of expected growth impact is quite minimal. So, I think these results again highlight that we can't just kind of use observational associations to predict what we expect to see in interventions. And we should be limited in our expectations for impacts on growth. Yeah.
What if you were to just look at the increase in mean LAZ in children who are already moderately or severely malnourished or stunted?
Great idea. Yeah, I could do that in MALAD.
I think you maybe there's a huge group of kids who are not going to see any benefit, which is probably killing that.
Yeah, exactly. So this is simulating intervention where we just went into the MALAD population writ large and gave them the vaccine.
Right.
But you're suggesting maybe more effective intervention would be to target, right?
Malnourished. You just care
Yeah,
about.
maybe you need to target to malnourished kids and then you see a bigger impact. So I like these methods because they can be very flexible and you can kind of simulate variations on targeted interventions in different ways. All right, I think we're actually done. So we have covered a lot of topics. As James mentioned, this has been really fun, collaborative work based out of UVA, and really appreciate you all hanging with us. There's obviously a huge number of people to thank and our collaborators around the world for this work. Yeah, happy to take some more questions. I don't know what time it is. My watch stopped, so hopefully we're not too close to the end of the time.
People have to go, feel free, but yeah, we can stay around a few minutes.
Yeah, okay, sounds great.
Quick question. In the slide 2 maybe. So is it true that MALAD has cognitive outcomes measured at 6 months and at 24 months, like 3 time points?
Yeah, it was 3 different time points, 6, 15, and 24, I think. Most of the work that has been published has just been focused on that 24-month time point.
And then there was
That
another,
exists.
there was another study, Elevate, the second one, that has also both cognitive outcome and growth outcomes measured.
It's just at 18 months. In the illicit study in Hyden, that was just at 18 months. Yeah, Kirk.
In the really interesting data about birth month and kind of what was happening seasonally in that population, are you able to overlay on food security, also dietary diversity and actual maternal nutritional status? Because food security is just one very small part of nutrition, obviously, and dietary diversity would be looking at micronutrient status. Obviously, makes sense. Micronutrient status in the first trimester might be affecting cognitive outcomes at age 2. And it's probably a bit of a fallacy to assume that food security right now indicates somebody's nutritional status. It might be food security like over the last 3 months more, I don't know. So
Yeah, no, thanks for those thoughts. So I guess the first thing is that all that I showed you was ecological, so bad on me, ecological fallacy. But what's really interesting about the food insecurity is that you don't see like any individual level association. So we think there's something interesting sociologically going on in Hyden where people at a population level, food insecurity makes sense related to the harvest, but at an individual level, it's not a great indicator of that specific family. So you go to Hyden and people say they're doing fine and they're clearly not doing fine. So specifically looking at the individual level with food insecurity really doesn't work at all. We have looked at kind of MALAD collected a ton of nutritional information. It's really hard to work with. It's hard to get at quantities. The seasonal availability of foods is an issue. The paper that we published in AJTMH goes into it a little bit, but it wasn't super compelling. But that's also not our particular area of expertise, and so I think there could be plenty more work done there. We're definitely interested in breast milk quality and illicit, especially because we see this kind of maybe the 6, around the weaning time point. It's important. So yeah, more to come there for sure.
sites, the site that had the most reported food insecurity was Brazil. Yeah, before you worry, it's really what you're asking in that question.
Yeah, it's a very subjective measure, but at a population level, it works.
Awesome. Thank you both so much. That was amazing.